Drugs for Type 1 and Type 2 Diabetes mellitus. This lecture will cover slides 120 to 138 of the slide pack. This is the last part of our slide set. Dipeptidyl peptidase 4 inhibitors. If you look in the lower left portion of this illustration, you see a yellow-colored shape that says DPP-IV enzyme inactivates GLP-1. And so GLP-1, if you recall from our lecture on GLP-1 and exenatide and liraglutide, if you recall, the human GLP-1 is actually not a practical selection for a drug. Okay, the natural hormone is effective after you eat, and your gut releases some GLP-1, and we have an incretin effect. But to administer GLP-1 exogenously, we run into a problem because the DPP-IV enzyme is going to inactivate that peptide relatively quickly, and we mentioned that generally about 90 seconds, DPP-IV has cleaved GLP-1. And so we discussed during class when we mentioned exenatide or described exenatide and liraglutide that these drugs that end in tide are actually more related to the reptile sequence of exendin-4, which is the reptile incretin we had discussed in class that was initially discovered in the Gila monster. And so we mentioned some of the pharmacokinetic properties of exenatide, liraglutide. We mentioned the pharmacodynamic properties, which are summarized here on the right. So these drugs stimulate insulin release, inhibit glucagon release, result in a lowering of blood glucose. GLP-1 also slows the rate of gastric emptying, and it also has effects in the brain in creating a feeling of satiety. Right, so GLP-1 is a very effective incretin in the body, but as a drug, it makes a poor drug because it's rapidly inactivated, and so recombinant synthetics like exenatide, liraglutide last longer. They are not as quickly cleaved. Well, one of the problems of the exenatide or the liraglutide is that they require injections. And so the thought process was, well, what if we just inhibit the enzyme that degrades the incretins that get released following a meal from the gut? What if we inhibit DPP-IV? Wouldn't that be equivalent to allowing GLP-1 that the body makes to now persist longer and to have pharmacological efficacy? And so indeed, we have found that this is the case, that DPP-IV inhibitors block that enzyme from degrading GLP-1, and GLP-1 persists longer, so that we can see the benefit summarized here on the upper right in the lowering of blood glucose levels. And so the DPP-IV inhibitors are going to have the base gliptin in their name. Sitagliptin, saxagliptin were two of the first DPP-IV inhibitors that made it to market. In the current time, there are others on the market or approved by the FDA in the U.S. These include drugs like linagliptin. These include drugs like alogliptin. And in fact, I had sent you, or posted, I should say, in the professor's drive, a PDF file of some of the pharmacodynamic, pharmacokinetic properties of gliptins. And some of the data in that file suggests that alogliptin may be devoid of some of the adverse effects of some of the earlier gliptins like saxagliptin. And so we're going to get into that in a moment. But as you can see in the lower left here, the gliptins are pointing to the enzyme DPP-IV, and they're being shown here to inactivate that enzyme. But recent studies suggest that gliptins may possess an ability to inhibit other DPP enzymes. And in particular, there's been some evidence to suggest that particularly saxagliptin is able to inhibit DPPs other than DPP-IV, like DPP-8 and DPP-9. Those dipeptidyl peptidases are very important for normal T cell function. And so, could it be that some of the adverse effects associated with saxagliptin, for example, are due to the fact that we're dysregulating T cell function? And so some of the toxicities that have been reported for saxagliptin include things like skin lesions. And so could it be that the reason that those are occurring is because of off-target effects that are causing inhibition of other DPPs that are needed for proper immune cell function? And so in that PDF on alogliptin, there's also a discussion concerning that as well. And so now we're going to move on and talk a little bit about sitagliptin and saxagliptin because they were the first ones approved. But now, since their approval, which probably, I can't remember off the top of my head, but relatively recently, probably 2006, 2007, maybe a little later than that, since that time, other gliptins have made it to the market, like linagliptin, for example, and alogliptin. There's actually another gliptin called vildagliptin, which is approved in Europe and in parts of Asia, but has not been approved in the United States. Vildagliptin, due to concerns about skin lesion risk. So we'll mention all of this stuff again as we move forward. So dipeptidyl peptidase 4, DPP-4, is ubiquitous. It's a membrane-bound enzyme that has many roles in the body, roles in metabolism, in the immune system, in the endocrine system, which here we're primarily focusing in on. And in addition to DPP-4, there are other DPPs involved in immune system regulation. Again, DPP-8, DPP-9 are primarily associated with proper function, or their activity is needed for proper function of T cells. And so we believe that some of the toxicities associated with a drug like saxagliptin, which has not only an ability to block DPP-4 but other DPPs, may be due to those off-target effects on DPP-8 and DPP-9. So again, dipeptidyl peptidase 4 inhibitors are drugs that are helping the incretins work more effectively. So by inhibiting DPP-4, the GLP-1 persists, and it can be more effective in its pharmacodynamic action. Okay, so it's going to bind to those GLP-1 receptors in the beta cells and cause the beta cells to release more insulin. It's going to bind to GLP-1 receptors in the gut and slow down gastric emptying. It's going to bind to GLP-1 receptors in the brain and induce a feeling of satiety, so that will indirectly cause a decreased glucose burden on the body. Okay, so these are drugs that help incretins work more effectively. And sometimes people call them incretin mimetics. But in fact, the way they work is by inhibiting the enzyme that would otherwise break down the incretin. The predominant adverse effects of these gliptins, sitagliptin and saxagliptin, include an increased risk of infection, urinary tract infection, upper respiratory infection. And if we see this through the eyes of dysregulation of T cell function, that may be an explanation of why we see that particular adverse effect at a higher incidence than, for example, in patients not exposed to these drugs. Also, headache and sinusitis have been reported in some patients taking these drugs. Again, they prolong the activity of incretin hormones. The consequence of their action is to increase insulin release and reduce the secretion of glucagon. They have been used as monotherapy or in combination with the sulfonylurea or metformin or glitazone. Saxagliptin is more potent than sitagliptin. Right? It requires lower doses for efficacy. But both drugs are given once daily, and they're given by mouth. Let's talk a little bit about sitagliptin. This one is kind of easy in terms of pharmacokinetics. It's not significantly protein bound. It's not known to induce or inhibit P450s. And it's excreted primarily unchanged through renal tubular secretion. Okay, so most of it is just excreted unchanged. Excreted through either P-glycoprotein or another transporter called OAT, organic anion transporter. Now, because sitagliptin is primarily excreted into urine through P-glycoprotein or OAT, we have a potential for interaction with digoxin, because digoxin is primarily excreted through the P-glycoprotein. And so digoxin is a drug you've learned about in cardiorenal. It's an important drug in treatment of heart failure. But it's also going to be excreted through P-glycoprotein. So in this regard, we would predict the drug-drug interaction between digoxin and sitagliptin. Saxagliptin, on the other hand, is metabolized through phase 1 and phase 2 metabolism, with phase 1 being primarily mediated by the CYP3A4/5 enzymes. And so the dose of saxagliptin should be limited to the lowest dose available, particularly when co-administered with strong inhibitors of CYP3A4/5, things such as clarithromycin or ketoconazole or ritonavir. Again, this drug is having an incretin mimic action. Right? It's increasing GLP-1 release. Or I shouldn't say release, but stability. It's preventing the GLP-1 from being broken down. It is being released from the gut, but it's not getting broken down as efficiently as it otherwise would be. So it travels to the pancreas and has action on the beta cell. But if the patient is deficient in beta cells, such as what we see in type 1 diabetics, this drug will not be a useful treatment for said patients. Okay, so it's not going to be effective for type 1 diabetes or for treating diabetic ketoacidosis, but it is effective in treatment of type 2 diabetes. Now, I mentioned a little earlier that there is a gliptin on the market in Europe, which is not on the market in the United States, and it's called vildagliptin. And the reason why the Food and Drug Administration was weary to approve it was because there was some evidence that skin lesions and kidney impairment may be adverse effects associated with vildagliptin that kind of came to the surface during animal studies. And so the FDA wanted more experiments done and the manufacturer decided to withdraw the application. Okay, so the drug vildagliptin is used in Europe and, as I mentioned, in parts of Asia with prescription, but not here in the U.S. It's not approved. So when you see vildagliptin as part of a data table I show you in a little while, just realize we're not really focusing on its pharmacodynamic or pharmacokinetic properties, since it is not going to be prescribed or dispensed at the current time in the U.S. Now, there have been case reports of severe hypersensitivity reactions after the first dose, in some cases, to as long as 3 months of therapy. And so, in some cases, as quickly as after the first dose. In other cases, it's taken about 3 months of therapy to see some severe hypersensitivity reactions in some patients. Now, again, this is low incidence, but it's not no incidence, so we want to be attentive to this. Anaphylaxis has been reported, angioedema, exfoliating skin reactions, including those consistent with Stevens-Johnson syndrome. And so these may be due to, again, T-cell dysfunction because of off-target DPP inhibition. But nonetheless, keep a keen eye open to these possible unlikely but serious adverse events. Now again, getting back to the idea of off-target events, all gliptins exhibit a greater selectivity for DPP-IV than for other DPPs, and that's why they're classified as DPP-IV inhibitors. But there is a variability in off-target effects with respect to DPP-8 and 9. And because DPP-8 and DPP-9 are proteases that are responsible for T-cell activation, the off-target inhibition of those DPPs may be responsible or contribute to the toxicity. Things like immune dysfunction, T-cell dysfunction, impaired healing, and skin reactions are believed, therefore, to result from the off-target inhibition, the inhibition of DPP-8 and 9. And I'll show you some numbers to kind of give you an idea what that really means in a moment. This is a table that's taken from the article I posted for you on the Professor's Drive that focused on alog-gliptin. And here we have some pharmacodynamic and some pharmacokinetic parameters of the various gliptins that have been approved either in the US or in Europe. And so you see sitagliptin, vildagliptin, saxagliptin, alog-gliptin, and linagliptin. We're just going to put an X through vildagliptin column because, again, in the US, the drug is not approved at the present time. If we look over in the second row, it says DPP selectivity with respect to DPP-8 and DPP-9. What we see is that drugs like sitagliptin, linagliptin, and alog-gliptin are primarily specific for DPP-IV. However, drugs like vildagliptin and saxagliptin have a much lower ratio of DPP-IV inhibition to inhibition of these other two off-target dipeptidopeptidases. And so, in the article that I posted for you, the authors are pointing to alog-gliptin and saying, look, this has the highest DPP-IV selectivity of them all. Right? It has the highest one, greater than 14,000 for a ratio. Right? So this is mostly binding and mostly blocking DPP-IV. And so we believe, the authors are predicting, that alog-gliptin will therefore have less likelihood of immune dysfunction, of impaired T-cell action, of skin lesions, and so on. Now, whether or not that proves to be correct, post-marketing surveillance will help us understand. Alogliptin was only just approved in the recent year or 2 years. Okay, so people are only now really starting to be treated with it and to be monitored. So it would make sense that the highest selectivity for DPP-IV should be the lowest incidence of other adverse effects, but time will tell. Okay, so if you look at sitagliptin and saxagliptin, alogliptin and linagliptin, you'll also see certain rows here looking at kidney excretion versus liver excretion. And what you're probably noticing is that most of the gliptins, with the exception of linagliptin, are eliminated renally. Most of linagliptin is eliminated hepatically. So if you're thinking of using a gliptin in a patient that's got renal insufficiency, linagliptin provides an interesting alternative because most of it will be metabolized in the liver. Also, we don't know all of the drug-drug interactions of the gliptins at the present time. Again, all of them are relatively new to the diabetes treatment arsenal, having come out in the past decade or so. But we do know for saxagliptin that 3A4, 3A5 inducers and inhibitors could set up possible drug-drug interactions. And we do believe that for sitagliptin, there may be a drug-drug interaction with digoxin. It says unknown because we haven't really seen those types of drug-drug interactions in the literature yet. But since digoxin and sitagliptin are both dependent on PGP for elimination through the kidney, it would make sense that there could be such a drug-drug interaction. So I'm not asking you to understand the whole table, but understand the kinds of things we've discussed: the DPP-IV selectivity, liver versus kidney excretion, and metabolism, and possibility for drug-drug interactions. Now, recently, the FDA and the European Medicines Association published a statement on the topic of pancreatic safety of incretin-based drugs. And they published this in the New England Journal of Medicine. And if you read this paragraph on the left, it kind of summarizes their stance. The FDA and the EMA have explored multiple streams of data pertaining to a pancreatic safety signal associated with incretin-based drugs. This is going to include the injectables like exenatide, as well as the DPP-IV inhibitors administered orally. Both agencies agree that assertions concerning a causal association between incretin-based drugs and pancreatitis or pancreatic cancer, as expressed recently in the literature and in the media, are inconsistent with the current data. The FDA and the EMA have not reached a final conclusion at this time regarding such a causal relationship, although the totality of the data that have been reviewed provides reassurance. Pancreatitis will continue to be considered a risk associated with these drugs until more data are available. Is everybody going to develop acute necrotizing pancreatitis who takes a DPP-IV inhibitor or who takes exenatide? No. But one should be on the lookout for such rare but potentially very serious adverse effects. Both agencies continue to investigate, therefore, the pancreatic toxicity. Now, where was the part about pancreatic cancer? Let me see here again. I'm trying to find that. So they're saying they're going to still keep an eye on pancreatitis, and that both agencies are going to continue to monitor. Okay, so at the present time, it doesn't seem like the FDA or the EMA is willing to say that these drugs increase the risk of pancreatic cancer, but they do say that they're going to continue to keep an eye on this adverse effect of pancreatitis. Chromium. In recent years, much attention has focused on the clinical usefulness of glucose tolerance factor in treating patients with abnormal glucose tolerance. Glucose tolerance factor was first isolated from brewer's yeast and was found to contain one chromium atom in complex with single molecules of glycine, cysteine, and glutamic acid, and two molecules of nicotinic acid. It was found that the chromium atom is considered to be the active constituent of GTF, glucose tolerance factor. And so initial interest in glucose tolerance factor really started about 1929 when a paper was published describing the insulin potentiating effects of yeast extracts. And although brewer's yeast is the richest natural source of chromium, high concentrations are found in bread, beef, mushrooms, liver, and beer. And glucose tolerance factor can also be endogenously synthesized from dietary inorganic chromium. Now, the chromium we're talking about here is chromium-3, trivalent chromium. Chromium-6 is considered an environmental toxicant, a metal that's very dangerous. Is it a transition metal? I'm gonna have to get back to you on whether it's a transition metal or not. I should know that, but anyway, neither here nor there. The chromium plus 3 is used in biological systems in the body. The chromium plus 6, the hexavalent form, is highly toxic. And so here we're talking about which one, the trivalent chromium plus 3. So indeed, I looked up chromium, and it's classified as transition metal, which my instinct was correct. So chromium, trivalent, has been shown to be essential for efficient utilization of glucose both in human and in animals. The recommended daily allowance for chromium is 50 to 200 micrograms. And in chromium-deficient tissues, which aren't getting that RDA, glucose uptake by cells and oxidation of that glucose to carbon dioxide and incorporation of glucose into fatty acids and cholesterol are potentiated by chromium. So chromium helps to process this glucose. In fact, there has been a decrease in insulin binding and the number of insulin receptors observed when there's an absence of adequate amounts of chromium in the body. In animals, the first sign of mild chromium deficiency is impaired glucose tolerance, and this impaired glucose tolerance may result from unresponsiveness of chromium-deficient tissues to insulin. The insulin potentiating effect of chromium has been clearly demonstrated in chromium-deficient animal models. So it has been hypothesized that glucose tolerance factor, and particularly trivalent chromium, facilitates insulin activation of the receptors through formation of a ternary complex. Okay, so there's some evidence to suggest that people who are deficient in chromium may have improved hyperglycemia if they just become normal for chromium. Okay, so just something to consider here in terms of diabetes. Glucagon and glucagon receptor. The glucagon receptor is a 7-transmembrane spanning G protein coupled receptor, which is coupled to GS and activates adenylyl cyclase, resulting in the intracellular accumulation of cyclic AMP and the activation of protein kinase A. Now, glucagon, as you know, is going to increase blood glucose levels. So why on earth are we talking about glucagon as a drug in the diabetes section if we're already dealing with elevated glucose levels in the blood? We don't want to exacerbate that. We want to reduce that. Well, the answer is that glucagon is used as a treatment for hypoglycemia. So glucagon here is really being looked at as an antidote in someone who has become hypoglycemic, either due to an incorrect dose of insulin that was used, or an adverse effect of insulin, or an adverse effect of one of the oral hypoglycemics. Okay, so here we're talking about glucagon. We've talked about its receptor. Obviously, you're not using it to lower blood glucose. You're using it to restore normal blood glucose levels in patients who have become hypoglycemic. Glucagon is a physiological antagonist to insulin, which is produced by the alpha cells of the pancreas. Its metabolic effect is the catabolism of glycogen and the release of glucose from the glycogen into blood, as well as the induction of gluconeogenesis. Right? So we're releasing sugar from storage, and we're making more when we give a patient glucagon. There are cardiovascular effects and smooth muscle effects, which I'm not going to discuss or focus on. I'm just going to keep this story focused on carbohydrate metabolism and the effects of glucagon on that. So among other things, glucagon in this context is used to treat and reverse the symptoms of hypoglycemia. There is little toxicity associated with glucagon, some reports of nausea, vomiting, or diarrhea, some rare reports of hypersensitivity reaction, generally few serious adverse effects. And remember, if you could think back to that slide when we were talking about insulin, one of the antidotes to insulin overdose, which is going to cause hypoglycemia, is to use glucagon and to inject it into the patient. Right, so before moving on, glucagon in this context is being used to reverse hypoglycemia. Now, we're not particularly worried about chronic toxicity associated with glucagon because in the treatment of hypoglycemia, we're administering the drug one time. And so I'm not going to focus on other possible side effects because, generally speaking, the side effects are relatively mild for glucagon. And the drug is not regularly administered. It's administered once to treat the hypoglycemic incident. So the drug's not really around long enough, or often enough, I really should say. The drug's really not around often enough to really be bothersome to the body. So again, glucagon is commonly used to treat hypoglycemia. Occasionally it is used to reduce smooth muscle tone in the GI tract. It's also been shown to be effective in the treatment of anaphylaxis, biliary tract pain, beta-adrenergic blocker overdose, esophageal obstruction, and it's a pre-medication and endoscopic procedure. So glucagon is used for various kinds of things. Our major focus here really is in the treatment of hypoglycemia. It is contraindicated in patients who are hypersensitive to it. But again, generally speaking, it's the recombinant human form, and so we don't expect too much of that, although we won't say no, we'll just say very low incidence. It should be used cautiously in the presence of an insulinoma or a pheochromocytoma, which is a tumor of the adrenal gland. And the most common side effects are nausea, vomiting, rash, or other allergic reactions. Sodium glucose cotransporter 2. Sodium glucose cotransporter 2, also known as SGLT2, is a high-capacity, low-affinity glucose transporter located on the luminal surface of epithelial cells, which line the S1 segment of the proximal tubule and account for about 90% of glucose reabsorption. In diabetes, renal gluconeogenesis, glucose uptake, and capacity for glucose reabsorption are increased, while expression of SGLT2 seems to be upregulated. And the thought is that pharmacologic inhibition of SGLT2 could be a viable option to reduce hyperglycemia in patients with diabetes. If we look at this figure, particularly the left portion of this figure, we can see a schematic of the nephron with the glomerulus, the proximal tubule. The S1 region of that proximal convoluted tubule is where the SGLT2 receptors are enriched. They're present in high quantities. So if you look over to the right panel, you see in the S1 region, you have these SGLT2 receptors on the luminal side of that epithelial cell. And so sodium is going to start to enter the cell, and glucose is going to move into the cell as well as it gets absorbed from the luminal side into the cell, and then later through the process of GLUT2 uptake into the interstitium, we get release of the glucose, as you can see in the upper right panel. So the SGLT2 is on the luminal side. It allows both sodium and glucose to enter into the epithelial cell of that region of the proximal convoluted tubule. And once in, the glucose can pass into the interstitium, also through GLUT transporters, but in this case, the GLUT2 transporter. Okay, if we look down to the S3 region of the proximal convoluted tubule, we do not see SGLT2 anymore. We see a different SGLT. We see the 1 form. And so the drugs that we're going to talk about are working here at the SGLT2 cotransporter that we see up in S1 region of the proximal convoluted tubule. And the net consequence, by the way, of inhibiting SGLT2 is going to be to allow more glucose to just dump into the urine than otherwise would. And when more glucose dumps into the urine, in the old days, that used to be one of the tests that physicians ran. How much sugar is in your urine? Because sugar is not supposed to be in your urine. It's supposed to be reabsorbed and used in your body. But when you administer an inhibitor of the sodium glucose cotransporter 2, what choice is there? You're blocking SGLT2, so you're blocking the uptake of sodium and glucose. And so if you inhibit the uptake of sodium and glucose, there is no more glucose to go back into the blood and get reabsorbed through GLUT2. And so S-GLUT2 is an important new target for the efficacy of certain drugs. Now, as I mentioned, the glyphosins are those certain drugs. There are two currently approved in the United States, canagliflozin and dapagliflozin. Now, last year at this time, canagliflozin was the only one approved in the U.S., and dapagliflozin was not approved at that time. The manufacturer was asked to do more studies because some of the clinical work suggested an increased risk of breast cancer in response to the drug. And so what we now know is that no, there doesn't seem to be increased risk of breast cancer with dapagliflozin, at least none reported thus far in humans. So just to recall that SGLT2, high-capacity, low-affinity glucose transporter, found in the S1 segment of the proximal tubule on the luminal surface. It helps bring in glucose as well as sodium. And when the glucose comes in, we get reabsorption of glucose from the urine. And so if that process is disrupted in any way, you're going to have a lot of sugar in the urine, which is kind of counterintuitive because that's one of the tests doctors use, your blood sugar levels in your urine, as an assessment for diabetes. But in these particular patients, the SGLT2 on the luminal side, when inhibited, is going to keep that sugar inside the urine, and eventually the body is going to dump it. And so a patient may be not diabetic, but they are going to have sugar in their urine. Does that make sense? Okay. In this study, diabetic patients were put into either sitagliptin group or a canagliflozin group. And changes on A1C, hemoglobin A1C, changes on free plasma glucose, body weight, and such, were monitored over 52 weeks. What we found was that over 1 year, both sitagliptin and canagliflozin 300 milligram dose were able to reduce hemoglobin H1C values, and they were able to reduce free plasma glucose values. And so both drugs are efficacious here, but compared to each other, let's see, are there any big differences here? Compared to each other, there is a change, a larger change in HDL and LDL than we see with sitagliptin. But otherwise, generally, there is no difference in terms of their effects. Okay, the major difference is going to be in the free fasting plasma glucose levels, and we see that canagliflozin is superior to sitagliptin in that regard. Here we're looking at glimepiride or canagliflozin at 100 mg or at 300 mg. And these are people who have been treated all year long, put into these groups and treated for 52 weeks. And what can we say in terms of efficacy? All of them are 7.8 in terms of hemoglobin A1C. In terms of mean change, it seems that the drugs are all pretty equivalent in terms of that. The difference in terms of 95% confidence interval versus glimepiride, canagliflozin and 100 milligram compared to canagliflozin 300 milligrams. And so what do we see? Well, we see that, versus glimepiride, the 100 milligram was effective, but the 300 milligram was more effective, okay, at changing this baseline. If you look down to the figure below, what you see is changes in hemoglobin A1C over time, with either patients in the study taking canagliflozin or glimepiride. The glimepiride is indicated by the red line and the red symbols. The canagliflozin 100 milligrams of canagliflozin 300 milligrams are represented by a green and blue box. And so what can we say? Well, it looks like canagliflozin is capable of reducing the hemoglobin A1C levels, particularly the 300 mg dose, compared to glimepiride. All right, we see that both doses of canagliflozin are active. And so that's an important finding, because all these drugs are going to be efficacious for reducing blood sugar and hyperglycemia. Okay, so even dapagliflozin, which is not depicted for you here, in terms of mechanism, is going to target the SGLT2 receptor, and in so doing, patient will dump sugar into the urine. This slide is looking at incidence of hypoglycemia in the various patients in the study, those treated with glimepiride only, or those treated with both 100 or 300 mg of canagliflozin. If you look at the pink bar, that represents the documented hypoglycemia episodes in patients with glimepiride. 34% of patients in the study developed hypoglycemia while on glimepiride, so that's a relatively large fraction. On the other hand, even the 300 milligram dose of canagliflozin was not capable of inducing hypoglycemia, which was a desired outcome as well. Okay, so less risk of hypoglycemia in the glyphosins compared to glimepiride. Now, in terms of adverse effects, canagliflozin was compared to glimepiride in various types of rows. And so let's look at some of these rows and see what they mean. Well, if you look at any adverse event, the values were all about the same. And the same can be said of adverse events leading to discontinuation. And the same can be true about adverse events related to study of the drug study. Now, in terms of serious adverse effects, one to pay attention to is genital mycotic infection. And in genital mycotic infection, we see an increase in the canagliflozin treated patients compared to those treated with glimepiride. Why do you think that is? Because you're keeping more sugar in the urine and the bladder, and so these opportunistic fungi can grow. If we look at urinary tract infections, there doesn't seem to be a large difference between glimepiride and the glyphosins. Okay, so as you study, keep this sheet in mind, particularly adverse effects which could be rare but easy to measure, and Keep in mind that in the male or the female, we can see mitotic infections. This is a list of the different glyphosins that are in the pipeline. Again, canagliflozin, as you can see, was approved by the US FDA in June of 2012. Dapagliflozin, another member of the class, was rejected by the FDA, but has since been accepted by the FDA with the condition that all patients will be closely monitored for toxicity. So currently today we've got canagliflozin, dapagliflozin. Now, your article on SGLT2 cotransporters mentioned that one of the reasons why the FDA held off on dapagliflozin was because it appeared that in animal studies there was a higher risk of breast cancer in patients who used dapagliflozin. This information presented in this course is based on reference materials that are believed reliable and consistent with standards accepted at the time of presentation. Possibility of human error and ongoing research and development in medical sciences does not allow assurance that the information contained herein is in every respect accurate or complete. The information presented during the course is intended for teaching of undergraduate and graduate students in biomedical education and is intended only for teaching. Students who successfully complete this course should check the product information sheet included in the package of any drug they plan to administer or dispense to be certain that the information presented in this course is accurate and that changes have not been made in the recommended dose or in the contraindications for administration. July 9th, 2014.